I have the honor of introducing our next two speakers. The topic they're going to speak on, as you can see on your agenda for the day, is addressing stigma and what we say matters. This is a really, really important topic when we are talking about MNO. It's also an extremely important topic in anything that we do to care for patients. The words we choose and how we speak is crucial to how we partner with moms and dads and families in taking care of them. So I will stop talking so we can hear from them and learn to choose better words and speak better. But our first person is Kristins Story. She is, I need to put my glasses on, hold on. She is a board certified in family medicine and addiction medicine. She completed an addiction medicine fellowship in Seattle, where her passion for caring for pregnant women with substance abuse disorder began. She works in Ohio now and is working with family medicine residency program. And is it started yet, the new fellowship?
It starts, if you know anybody who wants to apply, it starts next year.
She has developed and is starting a new fellowship in addiction medicine. So if you're interested in applying, it starts next year. Then Kristen Story, who I had the absolute pleasure of having dinner with last night as a group. She is a full-time employee, a student, a friend to many, a mother to 4, a fiance to 1. You didn't include this, Kristen. She's a master crafter, and she's a recovering addict. She has been clean for almost 8 years. In October 2014, she spoke at the Vermont Oxford Network's annual conference on her experience of being a mother of a premature baby and also as being a mother in recovery. She continues to utilize any opportunity to share her experience and knowledge in hopes of helping those in active addiction, in recovery, and the families and medical providers. We thank her so much for being here. I asked her before I stood up here, I said, "Are you nervous?" And she said, "No." So I'm still going to honor your courage because I don't have that. So thank you so much for being here. Thanks, you guys.
All right. A lot of what I have to say, actually, my colleague, Dr. Prasad, already said, so that makes it easy for me. I appreciated how she quoted Michael Botticelli around the importance of a personal narrative. I think we'll hear that from Kristen. I think my personal narrative is that I wanted to be a family doc because, I want to help people. I always imagined I would go somewhere where I was really needed, maybe in rural New Mexico or somewhere where I get paid in chickens, or taking care of AIDS orphans in Africa. And then I realized during residency that you don't have to look far to find an underserved population of patients. And when we're talking about patients with substance use disorder, that's even more true. Even today, you can walk into a hospital and see patients who are not treated adequately. And so I think, babies are cute, and I think somehow I got pulled into NAS work, and that's great because everyone loves babies. Democrats love babies, Republicans love babies. But like Mona, I think, babies, they come from these amazing women, and so we want to really shape the future by helping these women. But also, I have a bias towards bringing addiction as a chronic medical disease into the healthcare system in general. So bear with me as some of my scenarios are not specific to pregnancy, but I will do my best to bring it back at the end. So when we watch the news, and I hate this because even when I get reported in the news, there's just so many things that are wrong with these, the smallest sufferers, drug-addicted babies. One of the things that we're going to do during this talk is I'm not actually going to teach you everything about stigma and decrease all of your bias, but we're going to talk about words and how important they are, because I want all 450 people in this room to be cool. It's very important to me, and so I want you to know, and I'm sure you already do, that babies are not born addicted. Addiction is a medical disorder that is, related to our lack of control around drug use. It's a medical disorder that individuals have, but babies don't. They're physically dependent. So stigma starts in our news media as well. So why don't individuals just get help? And so it's estimated that over 23 million Americans have substance use disorder, and only about 10% of them receive treatment. And there's lots of reasons why people don't receive treatment. One is maybe they're not ready yet. But I think often, especially in my community and probably in yours, there's not enough beds to treat the people who want those services. And then stigma impedes people's ability to get to treatment. We'll talk about that. Substance use disorder is one of the most stigmatized medical conditions across the world. So they looked at 18 countries, and illicit drug use was the #1 stigmatized medical condition. And this also included HIV and having been recently incarcerated. So I think that says a lot. I'm going to go back. Okay, I'm going to let you know that I shamelessly stole the next example, but I will cite it, and also I will give you the resources at the end. But I'm a big fan of Dr. Sarah Wakeman in Boston. There's some Harvard medical series on substance use disorder. I've seen her present this case, and I think it really pulls out why it's important that we look at how our systems treat these patients. So this is an example. So let's say a patient was admitted to the hospital with a heart attack, and she's told it's her fault because of her poor diet, her stressful job, and her history of tobacco use. So she's given a list of cardiologists to call to get a catheterization, and she's told that we can't give you any medications yet because you need to see the nutritionist first. And she's sent home with a stern reminder to not have another heart attack. I hope that that's ridiculous and that we would all expect the Department of Health or Joint Commission to be visiting our hospital shortly. However, when we look at patients with substance use disorder who are a patient who's admitted with endocarditis, she's told it's her fault because of her substance use disorder, is given a list of treatment providers to call, and she's told she can't get into the treatment program until she sees a counselor first, and she's sent home with a stern reminder to not use drugs. And I actually think, even in my own organization where I really advocate for doing better, we still do this a lot. And so we're not meeting addiction with the same lens as we're meeting other chronic medical diseases. And so I think one of the other reasons that people have stigma is when people feel like it's a control, you have control over your decisions, right? And so addiction, sometimes people believe this isn't a medical disorder, this is something people have control over. And I think it's important to think about any chronic medical disease. There's a point where you have a choice. And it's important that you respond with good choices, right? So if you have heart disease, it's important that you take your medications as prescribed, or that you don't, that you eat healthy or watch your diet. And so I think, but when somebody has congestive heart failure or diabetes, so even with a poorly controlled gestational diabetic, we admit them to the hospital. We have a nutritionist see them. We work on adjusting their insulin dose. We make sure they have good outpatient follow-up. But again, if that same patient comes to the hospital with opiate use disorder, we may not meet them with that same level of engagement. So obviously, I work with Mona. We did not plan our slides, so my apologies for showing the same slide. So I'll try to say something different. But so one of the things that I think about is that addiction is just like any other chronic medical disease. And sometimes we forget that in the healthcare system. And I try to remind both myself and the residents that I work with that healthy people don't come to a hospital, right? And so you don't see a well-controlled diabetic in the hospital. You don't see that asthmatic who's taking their medications, inhalers as prescribed. And you don't see patients in recovery at your hospital because they're doing well, right? And we were at our last, at the OPQC meeting this week, one of our speakers said something about life is an outpatient experience. And I thought that was great because really the people who are doing well, it's not what's happening in the walls of our hospital, it's happening outside of there. So stigma matters to our individuals. So stigma is a really big barrier, and I think when we think about that 10% of patients who are getting treatment, they're not getting treatment because they don't have the support to do that. They avoid seeking help. Also, we have studies that look at people who are in an environment where there's more stigma. Even when they do go to treatment, they're less likely to sustain in that treatment. I have a patient that in Ohio that will speak with me, and she frequently says, I'm not a bad person trying to get good. I'm a sick person trying to get well. And I think that idea of these are bad people doing bad things is pretty pervasive. I also want to think about, there's 450 people in this room. There's a good chance that people in this room might have problems. So I think about that last bullet, fear of losing your job, family and friends. Think about what you would do if your colleague at work came to you. And I've really struggled with this in our work environment because I'm out preaching that addiction is a medical disease. And if you have a problem as an employee of our organization, you're done. And that's a really mixed message to be sending. But just think about what you would do and why the stigma is such a big deal. And then for us, as part of the healthcare team, we're often not given a lot of training around substance use disorder, in our medical education. And because of that, we often have less empathy for these patients. We also may not want to spend as much time with them, partly because we don't know how to talk to them. We don't know how to deal with that particular medical problem. So this is actually based on a study. We don't need to read all of this, but this is, there was a study where they took clinical, like 600 people, we'll talk about it on the next slide, but they gave them 2 different vignettes, and all they changed about the vignette was Mr. Williams is a substance abuser versus Mr. Williams has a substance use disorder. So just one word, and it's only in the vignette twice. And what they found, looking at 600 doctoral level of clinicians, so these aren't the beginners, when they were given the same description of the patient with that different word, a substance abuser, there was more leaning towards that patient was a threat, that person needed punishment, that he was blamed for his drug use. When we use the word substance use disorder, that was a patient then that needed treatment, that he had a problem that he needed help with. And so again, I'm gonna call out things that I want you to remember. Using the word drug abuse is really kind of going out of fad for lots of reasons, but one of them is that it leads to a lot more stigma. But also it's not diagnostically as helpful. And so using words like substance use disorder, addiction, opioid use disorder is really the words that we want to think about using. So this is just, I liked this, again, not about, it's not even about opiates specifically, but it was in a recent journal this year in the Journal of General Internal Medicine. They were looking at, gave vignettes to our learners. So they were looking at medical students and residents. The vignette is around a patient with sickle cell disease. So they used vignette 1 is with less stigmatizing language and vignette 2 with more stigmatizing language. So one of the bullets of the difference is, so about 8 out of 10 pain crises per year versus patient is narcotic dependent and in our ED frequently. He spent the afternoon with friends. He was hanging out with his friends outside McDonald's. So then they looked at 2 outcomes from these folks. They looked at attitudes towards the patient. And so this wasn't a familiar scale to me, but the positive attitudes towards sickle cell patients. There was a 5-point difference, which was statistically significant on a 35-point scale. And they also looked at, even though it was a vignette, kind of they asked questions about what would you do next. And they would definitely be less aggressive with their pain management in the patient with the stigmatizing language. So I think not only is it important what we say, it's also important what we're writing. And again, one of the things I tend to do is when you can go into your EPIC, the diagnosis codes are not so great for addiction, but if I see somebody who wrote like drug abuse, I will go in and change it to more appropriate language like opiate use disorder. So we'll go into a little bit about pregnancy. I know that this is a bit busy of a slide, but I think it makes a few great points. So the red bar is our non-pregnant women of childbearing age. The gray bar is pregnant women. And then the blue bar is non-pregnant recent mothers, I believe, within the last year. So a couple things. One, I think, during pregnancy, illicit drug use, alcohol use, smoking, it does go down quite a bit. So I like to believe that I'm pretty important as a doctor, but turns out lots of women stop without me, right? And so if they can't, those also are probably women who are struggling with some sort of substance use disorder if they're not able to stop during pregnancy. I think the other thing that is so impactful from this slide is just how quickly that line goes up after delivery in that postpartum period. So I think it's easy when we're looking sort of just through the lens of pregnancy to think of this woman as a woman who is pregnant who happens to have a substance use disorder, but really that's a woman who has a substance use disorder who happens to be pregnant. Because that substance use disorder is a chronic disease that's going to be, likely has been there before they were pregnant, and something that they'll struggle with well after. So it's really important that we use pregnancy as an opportunity to engage them for much longer. Also, I think in most of our states or municipalities, there's a lot of rules. There's a lot of even laws, but that prioritize.
They come back.
It does, okay. That prioritize pregnant women getting into addiction treatment. But again, just like our 10% of people who get treatment, women just in general who need treatment less than 20% are receiving it. And when we look at studies that look at, like, are our pregnant women getting into care sooner? Well, they're not getting in any sooner, and they're not getting in any more frequently as well. So there's really lack of evidence that these women are getting that preferential access to care. And I think this is interesting because I think in your Illinois data you had very similar numbers. So this is looking at a hospital in Florida around their NAS numbers, and they looked to see how many of those moms were in a treatment program versus were using illicitly, and only about 40% of the mothers were in addiction treatment at the time of delivery. But then I think the last bullet, or the last point also, is that, we're sitting in this room to help solve some of these problems, but even though only 40% were in treatment, when they were actually in the hospital, there was only 6% of the mothers received some sort of referral for addiction treatment during that birth hospitalization. So might have been an opportunity missed for some of those patients. So I'm going to go through a couple of cases and try to be respectful of time as well. And I'm going to kind of go through the first case of just looking at language. And then I'm going to ask you to, if I can be cautious about time, ask you guys to be a little involved in what you might say differently. So I know you're working on screening for substance use disorder in pregnancy, and so we'll kind of give the less ideal scenario first. So my name is Mary. I will be your nurse while you're here on labor and delivery today. Given that you've not had any prenatal care, I will be asking questions about drug abuse. And the patient, they've decided to use the NIDA quick screen, so she does that. Additionally, I noticed that a drug test was done in the emergency department and that you were dirty for opiates. Why have you've been using drugs while you were pregnant? So maybe not perfect, but maybe this is a little better. So my name is Mary. I'll be your nurse while you're here on labor and delivery today. I'd like to ask you a few questions that we ask all of our patients to help us to give you better medical care. These questions are related to your experience with alcohol, cigarettes, and other drugs. Completes the survey. Additionally, I noticed that when you were in the emergency department, they performed a drug test that was positive for opiates. Tell me more about your opioid use, and what can our team do to help you? So I want to point out a few areas where I think language matters. So one, hopefully you're actually implementing this with all your patients, not just saying so. But really, we shouldn't be calling out people based on whether they got prenatal care or how many tattoos they have. Because that's what we sometimes see happen on labor and delivery. But we should actually be implementing these screening questions with all of our patients. Again, I really want to make sure that you're all cool. So drug abuse is probably not the right word. There's other ways you could say it besides, this. We're doing this to asking questions related to your experience with alcohol or cigarettes or other drugs, or just your experience with other drugs. The words clean and dirty are also pretty stigmatizing when you're referring to a person or when you're referring even to a drug test. So really being, and we do that in medicine with each other, so I really encourage my learners to think about, that's not really medically helpful if you tell me your drug test is dirty. I want to know, what is it positive for? What does that tell us? I also think that open-ended questions are really important when we're talking to patients in general. And while why is an open-ended question, technically, it is the one I would avoid. As you can tell in that scenario, why can have a lot of negative connotation, really assuming poor intent, right? Like, why didn't you do the dishes yet, right? That's not really an open-ended question. So the other piece that I didn't underline is then really offering help and letting them know that there's hope and there's things that we can do to help them. I'm not sure how many minutes I have left. Just 5? Okay. All right. Okay. So I guess I'm going to go through, I guess I'm not going to engage you in conversation because I don't have time. But I know that in our breakout sessions, we'll be doing a lot more with this. So this is another scenario. We'll go through kind of in a few different ways and talk through what words might be better to use. So again, the first part of this, so this is really engaging mom in the care of newborns, and I think Vicki will have a lot more to say about this later. So my name is Stacy. I'm one of the nurses who will be helping care for you and your baby today. I understand that you've been on substitution therapy for your opioid abuse during this pregnancy. What are your plans to get into recovery and be truly sober? Lots of things wrong with that. I hope that you feel that in your soul. So the first thing is substitution therapy. This is not, we're not substituting one drug for another. This is a treatment for addiction when patients are on buprenorphine and methadone. So you've heard us use the word medication-assisted treatment a lot. There's a lot of people in the addiction treatment world that actually want to drop the medication-assisted part, right? We don't call it medication-assisted treatment for diabetes. We don't call it medication-assisted treatment for asthma. We call it treatment or medication. And so maybe that's even more important, more appropriate way to say that. Again, opioid abuse, hopefully I'm bringing that home. You could use lots of other words: addiction, substance use disorder, opioid use disorder. Sometimes, if they're not really owning that yet, I might just talk about struggles with opiates or some other word to get to that same point. And again, people who are on medication for substance use disorder can be in recovery. Not everyone who's on medication is in recovery, so I would say, they're not embracing the idea of being sober from everything else, but it is not, you certainly can be. Right? Methadone and buprenorphine are very much part of a recovery program. So given your buprenorphine use, your baby is born addicted. I can't even say it hurts. And we will need to monitor her for withdrawal. She's beginning to show signs of withdrawal now. I'm concerned about breastfeeding, given your drug use. I would not encourage you to breastfeed. We don't want the baby to get more drugs than she's already been exposed to. So you guys are already talking about breastfeeding, which is great. So again, babies are not born addicted. They're born physically dependent. I think breastfeeding is a really challenging issue because we've also talked about how women maybe aren't just using one drug. So sometimes breastfeeding may not be appropriate for our patients. And one of the things that I think has really been important where I work is that we have some sort of policy and that everybody knows what that is. Because it's not only frustrating to us as clinicians when, I walk in and say something and then, lactation or nursing says something different. That's frustrating to everyone. That's super frustrating to the patient if one person's supporting breastfeeding and someone else isn't. And then if they are just using methadone or buprenorphine, that those are obviously, as you've discussed earlier, compatible with breastfeeding and should be encouraged. So the last part, the nurse says, it's important that I get a drug test on the baby, so please don't change any diapers without me in the room. I will also be monitoring for withdrawal, so don't feed the baby without telling me first. Do you have any questions? None of that is wrong per se, but it's very focused on the provider. And I think what we need to do is focus on team-based care and shared decision-making, remembering that the parents are in fact part of the team, and including them in that. And similarly, again, with sort of open-ended questions, I would say, do you have any questions? Well, this is very subtle. It's very different than what questions do you have. I think when we say, do you have any questions, that's yes or no. And if I'm a good patient, I should already know everything, so I'm just going to say no. But what questions do you have suggests that I know that you have questions and I expect questions and I'm ready for them. I think that's important. So in summary from my part of this talk, sort of what can we do next? I think, one is we can change ourselves, really focusing on that patient-centered language and becoming aware of maybe what the best language is. And if we're not sure, ask. And learning more about substance use disorders. So I am going to recommend, we've been doing a lot of nurse education. At my hospital, we've been utilizing Harvard Medical Center's Understanding Addiction series, and that's free online, and it's really useful. And then working on changing our systems, which is what everybody in this room is doing today. So improving interventions to address substance use disorder within the healthcare system, and then strengthening those relationships with our treatment providers to help these women get access to the care that they need. So I will hand off the rest of my time to Kristen Tula, who's going to share her story.
So I know she said I wasn't nervous, but I think it's finally hitting me. Or maybe it's just cold in here. I'll stick with that. So I'll start from the beginning. I grew up in Chicago in Rogers Park. Lived there my whole life, never left Chicago. My mom was a single mom and did her best to raise us. So my addiction started, I was 14 and I was raped. And I wasn't able to talk about it. I couldn't talk to family. I felt really alone in it, and a neighbor that I was close with, who was older, had heroin. And, you know, I wanted to try anything to help myself feel better. And it completely anesthetized all of my emotions, and that's the feeling that I was looking for. I didn't want to feel anything. I didn't want to face anything. And so it just started there and spiraled out of control. The subsequent years after that were filled with a lot of trauma, difficult relationships that involved more physical abuse, sexual abuse, and just the constant drug use. Things were so bad for me at one point. My mother, who I was not in contact with, took out a life insurance policy to cover my funeral because she didn't expect me to live. And I was really isolated and alone, had no friends, had no family. All I had was just this relationship with heroin. And then I found out I was pregnant with my daughter, Sophia. At that point, I had gone in and out of rehab. When I found out I was pregnant, had been on Suboxone for a couple weeks, wasn't doing really well. And so I decided to go for my prenatal care. And because I had no support system, no family, it was a really difficult time, and I didn't know what I was gonna do. And there was a social worker there. She just did everything she could for me. She was a huge advocate for me. She let me know that she cared. And it just took one person, just one social worker to change my life. Just that feeling, knowing that she cared, she understood, she wanted to help me, and she believed in me above everything else. You know, with me being isolated, and I understand I isolated myself from my family. You know, you don't see that when you're in addiction, but it affects everybody around you. And so I had nobody, and for her to be there for me and to do everything she could, and she was a huge advocate for me, and she helped me get into methadone treatment and, you know, made sure I got the care that I needed, wasn't just judged. You know, she worked with all of the doctors that worked for me. I was in the high-risk clinic, so I worked with numerous doctors. And, you know, she talked to me. She would talk to me for hours and just sit down and talk to me and tell me I could do things with my life, and that this isn't the only course for me, that I didn't have to end up dead, because that's where I thought I was going to be. I thought there was no help for me. It really changed my life. And so I regained relationships with family, with friends. I got my life back. So during that pregnancy, I was doing really well. I was clean throughout the whole pregnancy. Did things like Lamaze classes and planned my birth and did everything that a normal, happy pregnancy should be with my partner. And then I had my daughter early. She was born at 35 weeks. My water broke. It was actually Black Friday while shopping. And I had my daughter, and just being admitted to the hospital, I was told that I couldn't follow my birth plan, that they're not gonna give me the medication. No, you can't have any pain medicine. We're not gonna do that for you. You know, it has to be this way because you're an addict. I was treated like that. And then afterwards, my daughter was admitted to the NICU, and that's where it got really bad. There was so much shame and so much guilt. I wasn't allowed to hold my daughter. I wasn't allowed to breastfeed my daughter. I couldn't look at her. I couldn't feed her. I couldn't touch her. And for my partner, who had never done drugs, had nothing to do with this, he was treated the same way, and it created a rift between us. It was really hard, and I felt like she wasn't mine. I felt like she belonged to the staff and not me. She was there for 6 weeks, and it was miserable. There was no joy. There was no happiness. It was so hard to be away from her. I spent every waking moment at the hospital with her. I was there, you know, from the minute I woke up till they kicked me out. They're like, "You're too tired, go home." And just if the only good part was she was there for me, but the nurses, and I understand, and that was what was so difficult for me. It left me really ambivalent. because I see what the nurses see. I always says it takes a really strong woman to be a NICU, or man rather, to be a NICU nurse, because to deal with babies and they're sick and to go through that and take care of them is so much. And they have to deal with that on a daily basis and see what the baby's going through. So I can see that part of it, and that gave me more guilt. I didn't want to harm her. I didn't want to hurt her. I wanted to be the best mother possible, but I didn't feel like I could be that. And so finally I got to take her home, and things went really, really well after that, but a lot of the guilt and shame still remained, taking her to doctors. And then my middle child was born, my son, and he was born at 24 weeks. Nothing to do with, being on methadone, which of course, a lot of people will say that, and family would think that. Had nothing to do with it. I hemorrhaged and had a placenta abruption and just couldn't carry him. And I had him at 24 weeks. And it was a little bit of a different experience because of the severity of his medical issues. But after 8 months, he came home. That same feeling, being treated the same way and having just all the guilt and the shame. And that was the worst part. Just feeling like I was this horrible person for having children. Like I shouldn't have children. I shouldn't be allowed to have children. And it's, it felt like my cross to bear. That's what I've always told social workers, that, I put myself in this position and I deserve it. But I don't. That's the hardest part about all of this, is we're all people. We all have our own problems. We all have our story. And I just wanted to touch on one of the earliest studies that were done on trauma and female addiction. There's 74% of addicted women reported experiencing sexual abuse. Women who have had traumatic childhoods are 5 times more likely to use drugs and twice as more likely to abuse alcohol. And as many as 4 out of 5 women seeking treatment for substance abuse disorders report a lifetime history of sexual assault, physical assault, or both. It's so common. All the women that I speak to, I go to groups, I speak wherever I can. I speak to young women about sexual assault. I speak about having children on methadone. Whatever I can do to help, I do. And it's so common, the story of sexual assault, childhood assault, physical, whatever it is. It's so common. So there's so much behind this, and we self-medicate, not to, and then there's always been, I've been told that it's making excuses. But if we treat that as well, it kind of makes a huge difference. And we're all people. If somebody comes in as a victim of assault, that's one thing. But then if they come in with substance abuse disorder, they get treated differently. Whereas there's a story behind it. The stigma is so bad, and we don't feel like people anymore. Kids watch TV, and they see something on TV, and they see a commercial for a toy, and they're like, I want that. During addiction, I see commercials of people having normal lives, and that's what I wanted. I'd sit and think, that's what I want. It's so hard to get out of it. It only took one person, one healthcare worker, to help me out of it. And it's so hard to talk about. I think that, if we change the way that we look at people that have substance abuse disorder, it might, it'll make a huge difference. That's it.
Kristen, thank you so much for sharing your story with us. I think that understanding where our patients are coming from, understanding them as stories and as people, and not a diagnosis and a chart is what we all strive for. It's why we become nurses, it's why we become physicians. We want to take care of people. And sometimes in the day-to-day, the diagnosis gets in front of the patient. And I think that's the lesson that we can learn from Kristen and from her fiance, Jack. Jack, thank you also for being here. Jack's picture is there with the kid. And I think that when we all go back to our hospitals and our prenatal care clinics and our offices, and we're trying to implement universal screening and we're talking to patients about opioid use disorder, these are our neighbors, our community members, they're fellow physicians, fellow nurses, teachers. These are people with life stories. And I think that when we think about understanding stigma, when we understand trauma-informed care, all of us are going to be better able to be that social worker, be that person who reaches across and gives someone a hug and says, I see you as a person, and I am here to help, and we have a system in place, and we have resources, and we believe in you, and we know that by identifying moms earlier in pregnancy, by giving them the sort of supportive resources, supportive clinical care, we can get moms on that road to recovery, to have healthier pregnancies, healthier babies, and then go on to lead the lives that they want to lead. We were talking to Jack and Kristen last night about their new home in Rockford and the lives that they're building and the schools and education they're doing, and we were comparing notes about our favorite things to do, and both of us' favorite thing to do is make cookies with our children, and more brings us together than separates us. And I think that when we are caring for patients, no matter what their diagnosis is, but particularly our patients with opioid use disorder, our ability to see these patients as people and our ability to see that we do have treatment, we do have resources that can make a difference for these women's lives, and there is a treatment available. And right now, only 40% of patients are getting it at delivery, and we all here over this next year are gonna do our job to do better. So thank you, Kristen, for inspiring us.